State President of IAP, Dr. Narayanan, National Vice President, Dr. Anandakeshavan, Secretary of IAP Kerala, guest of the day, speaker of the day, Dr. Vaman Kadilkar, respected teachers, colleagues, and friends. Today is the 6th edition of the webinar series, Beyond Horizon, Meet the Doyens. Today, Vaman Kadilkar sir will talk on the most important basic subject of the pediatrics, that is growth charts as a diagnostic tool. Dr. Vijay Kumar, my colleague and dear friend, will chair the session. My present duty is to welcome you all on behalf of IAP Calicut and IAP Kerala. I welcome Vaman Kadilkar sir to this platform. I also welcome Dr. Narayanan, State IAP President, Dr. Anandakeshavan, National Vice President, and all other my dear friends and colleagues. IAP State President Dr. Narayanan already conveyed to me that to save time, he is not talking. He conveyed the best regards to Kadilkar sir and best wishes for this Zoom meeting. With these words, I invite Dr. Anandakeshavan, our National Vice President, for the inaugural remarks.
Good evening, respected Chairperson Dr. Ashraf, Secretary Dr. Nihas, today's chief guest, today's our respected Vaman sir, and today we got one more BIP, Dr. Rohit Agarwal from Mumbai, past national president. Rohit sir, welcome you, and dear friends and IAP family members. Once again, I would like to congratulate IAP Kozhikode for the wonderful session and the great speakers and a systematic meeting. Means they are conducting very regularly, very timing is very good and very interaction, and it is just like a family nowadays. And every Monday and Friday, we forced to sit in front of webinar by IAP Kozhikode. And today's topic also very important. Even we repeated in instruction from teachers like us. Even people are not measuring routinely the growth chart, not charting the height and weight. Just like our torch telescope, whatever it is, we have to use our growth chart also. Anyway, there are some changes are there definitely, and also there are so many changes in treatment aspects also, short stature, everything. So I think to discuss all these things, we have an eminent speaker. So welcome Vaman sir to Kerala on behalf of the South Zone IAP. And I wish the program all the success. Thank you. Jai Hind, Jai IAP.
Thank you.
Thank you, Dr. Anandakeshavan. Whether the Nihas Ramesh joined? I'm not seeing.
No, not yet, sir. Not yet, sir. We can continue with the session.
Then, but today's, I already said, today's topic is growth chart as a diagnostic tool, a case-based approach. The speaker is Dr. Vaman Kadilkar, and this session is chaired by my friend and colleague, and one of the pioneer in the field of pediatric endocrinology, pediatric and adolescent endocrinology, and the leader of the team in Kerala, in short. That is Dr. Vijay Kumar. Over to you, Dr. Vijay.
Thank you. Thank you, Dr. Ashraf. It is my pleasure and great privilege to introduce Dr. Vaman Kadilkar to this audience. Sir needs no introduction to this gathering. He has introduced IAP growth, IAP combined WHO IAP growth chart, growth velocity charts, BMI chart to us. He had more than 200 articles in the index journals and many textbooks, and he has many consensus guidelines, including one about management of vitamin D deficiency and rickets, which we are keeping on our desktop for ready reference. He is at present consultant Pediatric and Adolescent Endocrinology at Jahangir Hospital, Pune, and Bombay Hospital, Mumbai. He is the Pediatric Endocrinology Fellowship Guide at Bharati Vidyapeeth, Pune, where I had an opportunity to be an examiner along with you, sir, during the last Pediatric Endocrine Fellowship exam. And I, like many others, learned the art of growth chart monitoring from him. Actually, I just learned at 2009 Pedicon. I had an opportunity to hear his talk, and I still follow his art. That is, and I was lucky enough to be a faculty, co-faculty with him in many growth workshops during Pedicon and during many workshops conducted in Pune and around Pune. And he's the former president of Indian Society of Pediatric and Adolescent Endocrinology, and he's a council member of Asia Pacific Pediatric Endocrine Society. Sir, with lots of regards, I welcome you to Calicut again. Sir is coming for the third time, as we were discussing. First time in 2011 as a faculty in our second Indian Society of Pediatric Adolescent National Conference, and then next year for Kerala Pedicon. This year he was a faculty at Summer Pedicon Calicut, but because of the COVID, we couldn't conduct that program, and this is his third visit, but now in another platform. So we again express our sincere gratitude for accepting our invitation for delivering his talk, Growth Charts as Diagnostics Tools, a case-based approach. Sir, over to you, sir.
Thank you very much, Dr. Vijay Kumar, Dr. Ashraf, and Dr. Kesavan for this kind introduction and inviting me to speak on one of my most favorite topics of growth charts. So what I'm going to do today is I'm actually going to start with some cases, because what makes a talk very interesting is the case. And then after that, I would go on to talk about some basics of growth charts. So let's start now with our first case. You have a 4-year and 3-month-old boy who is referred for short stature. His height is 75 centimeter and weight is 6.2 kilos. Now I have shown you the growth chart already plotted here. And you can see that his height is way below the 3rd percentile, and so is his weight. In the history, you notice an important point that his birth weight was 1.7 kilo at full term. So this was a small for gestational age child who has failed to catch up, or in pediatric endocrine terminology, he is a short SGA. This is his clinical picture. And I would like you to note some of the important features. This boy has a broad forehead, a triangular face, and he's standing with an awkward gait, the reason of which you will realize in a minute. Now look at his hands. Here on his right hand, you can see the clinodactyly or incurvation of the little finger. It's seen on both sides. But now compare the size of these two hands. They are not at different level. They are at the same level. And you can clearly appreciate here that his left side is much larger than the right. And that's why he cannot straighten his left leg. It is longer than the right. So he stands on the right leg, but he has to keep his left leg bent so that he can balance it properly. So thin face, narrow chin, atrophy of the face and body, crowding of the teeth with unequal size incisors, limb discrepancy, and on his genital examination, you notice that he had normal genitals with both testes palpable. So remember the growth chart, he was way below the 3rd percentile for height and weight, and these are his clinical feature in an SGA baby. So what is the likely diagnosis? Now, in a case like this, you must consider the first diagnosis as Russell-Silver syndrome or severe short stature caused by an SGA. But asymmetry is typically seen in Silver-Russell syndrome. Now, what is the genetic abnormality in a child like this? And I'll come to that in a minute. Will growth hormone be useful to such a patient? And when will you start growth hormone therapy and in what dose? And how long should we give growth hormone for? So to answer the first question, I think this is Russell Silver. And we got the genetic test done on this child, and he had uniparental disomy of chromosome 7 of maternal origin. But in many children, you can get genomic imprinting abnormality of the 11p15. Both mechanisms can lead to the very same disorder. So if there are any postgraduates who are attending this is an example of uniparental disomy as well as genomic imprinting. Will growth hormone be useful? The answer is yes. This is a licensed indication of growth hormone therapy. When will you start? You should wait up to 2 years, but when the deficit is as severe as in this case, you should not wait for much longer. So you would start growth hormone at 2 years. And for how long? You should give it at least for 4 to 6 years. And in an ideal world, if the parents can afford, you will give it until final height is reached. So let's move on to our next patient. Now you know that the growth charts are color coded. So here you already see a pink color chart. So this is a girl child. And I have already said here, 8-year-old girl, short stature, way below the 3rd percentile. But look at the weight. In the last case, you had the weight also below 3rd percentile. Now here is a child whose weight is on the 25th percentile. And mom also tells you that she has had thelarchy, that is breast development. And surprisingly, for such a short child, menarche has also occurred. So this case is very different to the last case, where you had both height and weight deficit. Here the weight is preserved and the height is significantly less. So in other words, you have got a short and overweight child. These are her clinical pictures. You can see the thelarchy. You can clearly see that there's breast enlargement, but note that there are no pubic or underarm hair. And yet this child has got menarche. So a short child with discordant puberty. Very important words, a short child with discordant puberty. So you are not thinking of central precocious puberty, you are thinking of something else. So let's move on. Now, for some reason, this kid was admitted in the surgical ward, and because of menarche, they got her ultrasound done. As you can see here, these are huge ovarian cysts that you can see. Very large ovarian cysts, both sides. So here is a child who also has large ovarian cysts. And an MRI was ordered because they felt that she has central precocious puberty. And what you find here is a large pituitary gland. So the pituitary gland looks as if it has come out of the sella turcica, and you wonder whether there is a mass. But whenever there is discordant puberty in a short and relatively fat child, always think of an endocrine disorder. So we did a bone age, and here you can appreciate that the bone age is retarded. And also other hormonal profile was done, which showed bone age was 5 years, which is 3 years retarded. You have a low LH, a high FSH, a high estrogen, and a high prolactin. So whenever you have high prolactin, there are usually 2 causes. One is compression of the pituitary stalk by the tumor, or more commonly, primary hypothyroidism, because TRH will raise prolactin. So at this stage, fortunately, before the surgery was planned, we were called, and all that I had to do was order a thyroid function test, which showed a very, very high TSH, more than 1000, and almost unrecordable free T4. So here is a case of simple primary hypothyroidism that presents as pseudo-precocious puberty, and on treatment, everything will revert, including the menses will stop. So that's what we did. We gave her thyroxine in a small dose and repeated her MRI after 2 months. And now see what has happened to the pituitary gland. What was popping out of the pituitary fossa has completely shrunk and become normal. So what you were seeing as a pseudo mass was hyperplasia or hypertrophy of the pituitary gland, which completely reversed to normal. Her ovarian cyst disappeared. She started growing, and this child has eventually reached an adult height now of 152 centimeters, which is normal for her mid-parental height. So your growth chart here was telling you that this child is short and overweight. So this is an endocrine disorder. Another case of a 15-year-old boy who presented with short stature. His parents have noticed that he looks very immature and is not growing as well as his peers, mainly for last 2-3 years. He also has been a bit aloof in the last few days. His examination showed that for 15 years, he's clearly short. His weight is all right. And his sexual maturity rating shows that he has quite immature genital development for a 15-year-old child. We had his previous record, so we have plotted him. So he was growing between the 3rd and 10th percentile line throughout childhood. And during pubertal years, he has slowed down significantly and the weight has relatively increased. Now the questions are, what test will you ask for? Now, whenever you get a child like this whose growth chart is declining, you must always get a thyroid function test, as we saw. And in this case, do some very basic tests like hemogram, ESR, thyroid function test. Because he's way below the 3rd percentile, I also did an IGF-1 to screen for growth hormone deficiency, creatinine and urea. And everything came back normal. All tests were normal. So we did a bone age, and the bone age was 2 years retarded. So a boy who doesn't grow in puberty for the first time has bone age delay and everything else is normal. So what are the possibilities? I think here the possibility is pretty clear. This looks more like constitutional delay in growth and puberty, and you have ruled out hypothyroidism and growth hormone deficiency. So this is most likely a case of constitutional delay in growth and puberty. Or rarely, you get hidden chronic disease. I know that in southern India, celiac disease is not that common, but in northern India, it's very common. And we also see occasional case in Maharashtra nowadays, because there's a lot of migration in Maharashtra from all over India. And I'm sure it is the case in all metros in India. So always remember some hidden chronic disease like celiac disease or other inflammatory bowel disease, which may only present as growth failure. And sometimes psychosocial short stature can also manifest like this. So we did his hormones, his FSH has started rising, his testosterone is still low for his age. So we made a diagnosis of constitutional delay in growth and puberty. And normally what do you do for constitutional delay? Masterly inactivity. You do nothing. You reassure and you wait. And that's precisely what we did. And you can see that at 15.5, he started gaining his height and he reached his mid-parental target height by the time he was 18 years of age. So this is a classic case of constitutional delay in growth and puberty. Next case, 14-year-old girl comes with no signs of puberty. Her anthropometry is height 130, weight 35, sexual maturity rating pre-pubertal. So at 14 years, she's showing no signs of puberty. That will definitely be a cause of concern for an urban dwelling girl. In rural India, you may still get this as a normal picture, but this is an urban dwelling girl. Her bone age is very retarded. It's 9.5 years. So you can see here, she's short. Her weight is relatively preserved and her bone age is retarded. So quite clearly again, short and relatively fat, so likely to be a hormonal disease. Now look at her pictures. She looks like an 8 or 9-year-old girl, very immature face, and look carefully on the right side at the eyes, they are not parallel. There is a definite squint. And when you ask the mom, she clearly tells you that this is a recent onset development. So when you have a child on whom you suspect a hormonal disorder and a neurological sign, you are very worried because you are looking at some kind of a sinister disease that is also leading to pituitary hormone disorder. And these are her tests. Her LH is very low, FSH is very low. Her estradiol is also not detectable. So no hormonal activation of puberty. Her prolactin is high. And remember a couple of cases ago, I said, in two situations, your prolactin gets raised. In primary hypothyroidism or pituitary stalk compression. Her IGF is very low. So she is growth hormone deficient. That's why she is not growing. Her free T4 is low and her TSH is low. So this is not primary hypothyroidism that will raise prolactin. This is secondary hypothyroidism pointing towards pituitary. And the raised prolactin is actually pointing towards pituitary stalk compression. So this is a very serious issue. Her cortisol is also low. So you can see here she has developed panhypopituitarism except the prolactin. Her serum sodium, potassium, and osmolarity came back normal. And sadly, when we did the MRI, you can see this huge mass completely destroying the pituitary gland, compressing the pituitary stalk with cystic and solid spaces in between. Sadly, this was a very, very aggressive craniopharyngioma that had destroyed the pituitary gland. And now she is on complete pituitary hormone replacement because all hormones are deficient. So remember, if you see a case of suspected hormonal disorder with recent onset neurological signs, keep your index of suspicion for an ICSOL low because she had no other symptoms of raised intracranial pressure. Another case of a 15-year-old boy, micropenis, lack of puberty, short stature. He is really short and comparatively quite fat, and his mid-parental height is 163 centimeters. So I plotted it for you again, short, relatively overweight, and the mid-parental height is quite high here on the right side. This is his clinical picture. He looks like a 10, 12-year-old. He's short, he has immature face. He has central obesity. Definitely limbs are thin and obesity is central, and the genitals are very underdeveloped for a 15-year-old. So here is a kid who is showing all the cardinal features of growth hormone or multiple pituitary hormone deficiency. His bone age was retarded. His LHFSH were low. His testosterone was very low. His free T4 was low. His TSH was low or normal. His prolactin was also low. So unlike the last case, you have a child who has all the pituitary hormone deficient, but the low prolactin. So this is not a compression effect. This is likely to be congenital, or this is likely to be congenital maldevelopment of the pituitary gland. And he has a normal cortisol. So cortisol is preserved, but everything else is low. This is his growth chart. Now I have plotted the bone age for you. Sorry, I'll just go back. That's the bone age. So he had bone age retardation, significant short stature, relatively fat. We stimulated his growth hormone and all values were below 1 nanogram per ml. And this is his MRI. Now what I want you to look at is right here in the middle of this slide is you have a nearly absent anterior pituitary. Hardly anything can be seen in the sella. You have a thinned out stalk, and this is the ectopic pituitary gland, and that's the mammillary body. So ectopic pituitary gland, very thin pituitary stalk, and nearly absent anterior pituitary. So this is called as the pituitary stalk interruption syndrome. So you have thin stalk, ectopic pituitary, hypoplastic anterior pituitary, cardinal, the typical cardinal triad that you get with congenital or let's say pituitary abnormality seen as one of the genetic defects. And this is what you get, such as in PROP1 gene or PIT1 gene. This is more common in PIT 1 rather than PROP 1. So this is combined pituitary hormone deficiency. Now I'll move on to another case, a 16-year-old girl, no secondary sexual character, short stature. Again, height is relatively short as compared to weight, and bone age is not retarded. So this is the first time I'm showing you a case who looks like a hormonal disease without bone age retardation. So bone age retardation is not much, but she's quite short, and her weight is relatively preserved. That is her clinical picture. Now, many of you who see this clinical picture will straight away make a diagnosis, but I'll describe it for you. She's short, she has webbed neck, she has acanthosis, she has a shield chest, not very clearly seen here, but she had short fourth metacarpals, which is very beautifully seen here in the X-ray. Look at that really tiny short metacarpal. Remember, short metacarpal bones are seen in 3 conditions which are associated with short stature. And they are Turner syndrome, Shox gene defect, and hypo or pseudo-hypo or pseudo-hypoparathyroidism. So when you see this sign, you have to think of one of the conditions. Now here the diagnosis is glaring at you. These are her reports. She's hypothyroid, low free T4, high TSH. Her FSH is very high. Her IGF is normal. And this is her ultrasound of the pelvis. You can see the urinary bladder, but almost nothing in the place of uterus. Very tiny rudimentary uterus. So what this girl has is short stature with hypergonadotropic hypogonadism, primary ovarian failure, hypothyroidism, short metacarpal, most likely Turner syndrome. And this is her karyotype, 45X, with an absent X chromosome. So this is the case of Turner syndrome. So now in the next coming 10 to 15 minutes, I'm going to take you through short stature and some details of the growth charts. So the question is, really does stature matter? And if you ask a young child, they say, no, doctor, I am not at all bothered about my height. But when the same child gets to adolescent age, they'll turn around and say, I'm really concerned about my height, doctor, and you do something. Please make me tall. And often that's the time when it is too late and nothing much can be done. So it's important to pick up short stature early and refer at an earlier time. Now, why is stature important? Here you are, a very glaring example. That's Barack and Michelle Obama, and that's Sarkozy, the French Prime Minister with his wife. And look at his feet. See what the guy is trying to do. He is lifting his feet to become at least as tall as his wife. And see the heels that he's wearing. So if even when you are the French premier, if you feel that you are short, imagine a common man, imagine a common child. So pick up short stature early, it's important. But for that, how do you know that a child is short? Measure on an accurate stereometer. Please measure both parents. Whatever is the reported height by the parent, I always say jokingly, is directly proportional to the esteem in which you hold your own spouse. So if you think your spouse is great, you will always say that he or she is taller. So please measure both parents. Use the IAP 2015 growth charts, plot height and weight, and children below the 3rd percentile line are short or stunted and need to be looked at carefully. IAP has given you simplified chart for under 5 children. These are WHO IAP modified growth charts, and 5 to 18 are IAP charts. They are color coded. Use pink for girls and blue for boys. And percentile lines on the BMI chart are also color coded. 23 and 27 adult equivalent are taken as overweight and obese respectively. So these are your IAP 5 to 18 charts. Both height and weight charts have 7 percentile lines. They are 3rd, 10th, 25th, 50th, 75th, 90th, 97 for weight as well as for height. 50th percentile is the average, the mean of the community. Third percentile is the line below which a child is considered short and you must investigate or refer. Above 97th percentile is considered as tall, but very rarely people will come to you for tall stature. It is considered as an asset. So they don't tend to come to doctor. Only some girls who are very tall, where parents are worried about their future as far as their marriage and partner is concerned, may come to you and you find they're above 97th percentile. The BMI chart has one orange line and one red line. The orange line is for overweight and the red line is for obesity. Now blue is for boys, pink is for girls. So these are girls charts. Now for endocrinologists, they need to adjust the mid-parental height for the child's height at all ages from 0 to 18. So these IAP WHO combined charts were produced by the IAP Growth Chart Committee, and they depict height and weight from 0 to 18 years. They are also available on the IAP website to download. Now you all use the charts now. These simplified WHO charts are produced by IAP, but the centile lines have been reduced to accommodate in a single page. So you have the length, the head, and the weight. Here the orange line is the third percentile or -2 Z-score, and the red line is the first percentile or -3 Z-score for length and weight. For head, only up to third percentile is given because head circumference below third percentile itself is a worry. So you don't need to go down to first percentile. The charts on your right side are immensely useful. They are weight for length charts. So these are age independent criteria to define malnutrition. There are 4 lines. The orange line is the third percentile. The red line is the first percentile. Orange line is -2 Z-score. Red line is -3 Z-score. So any child whose weight for length falls below the orange line is MAM, moderate acute malnutrition. And anybody below the red line is SAM, severe acute malnutrition. Again, pink chart for girls, blue for boys. Now the Indian Academy of Pediatrics has also given you a growth chart application, which you can use on your cell phones. And it's very useful because not only this draws it for you, so you don't have to do any calculations of BMI, etc. And it even gives the interpretation at the bottom. Like in this case, height is less than third percentile. So this patient has stunting. Now, the second thing you do after you have plotted it is you ask yourself this question. When has my patient presented to me with short stature? Remember the ICP model of growth. If the patient is short in infancy, it is nutritional. If the child is present with short stature in childhood, then it's hypothyroidism and growth hormone deficiency. If for the first time in puberty, like we saw in the case of the boy, of constitutional delay in growth and puberty, then it's disorder of puberty. This simple model is very useful in clinical practice. I have put the same thing, sorry. I put the same thing here graphically. Infancy nutrition, childhood thyroxine growth hormone, puberty sex steroids. Now the mid-parental height or the family height. Mid-parental height is also known as corrected mid-parental height or target height. And it is calculated by the formula as father's height plus mother's height plus 13 divided by 2 in a boy and -13 divided by 2 in a girl. Now I have taken an example here. A 9-year boy, height 116, weight 20, dad 157, mom 150. Target height works out to be 160. Then there is a target height range. For the IAP chart, we have given 6 centimeter above and below, which shows the 10th and the 90th percentile for the family. But if you read Nelson textbook of pediatric, it says 8 centimeter below and above, because Nelson has given 2 SD, 2 standard deviation around the mean. So it depends on what you follow, but most children would fall between plus and minus 6 centimeter around the mid-parental height. So the same can be seen here on this graph. Now, if you look at your slide carefully, the arrow goes up now and it will stay at 157 centimeter. And then 6 centimeter above and below this is the target range. Now you see this arrow, which is pointing downwards. That is where is the bottom line for this child. And if you draw a line close to this, you will see that this child which appears short is actually falling within the mid-parental percentile. So you are okay. This is familial short stature and just needs observation. So what next do you do? He is below 3rd percentile. He is also below the family percentile, but between the target range. Now you need to watch for growth velocity. Growth velocity is the speed of growth seen over at least 6 months, ideally 1 year. One important thing is how far below is the child as far as the 3rd percentile is concerned. If the gap between the actual height and 3rd percentile is very wide, that means the child is way below the 3rd percentile, then you should investigate immediately and not wait. But if it is just below, then it is likely to be familial or idiopathic or chronic malnutrition or chronic disease, which is hidden. If it is way below, then you are looking at hypothyroidism, growth hormone deficiency, skeletal dysplasia, or a syndrome, or rarely very severe chronic disease, but then it is overt. Usually such chronic diseases are overt. You can pick them up clinically. So this little cartoon shows it nicely. If this is where your height percentile is falling, then you are thinking of idiopathic or familial short stature, constitutional delay, chronic mild malnutrition, or an SGA sequelae. But if it is as low as this, then it's a skeletal dysplasia, endocrine disorder, a syndrome, bone disease, or very severe systemic disease. Then you need to understand height velocity. Height velocity graphs are different. I have shown the Indian height velocity graphs here. And what you see are percentiles. Remember, what is important is height velocity chart's danger line is 25th percentile. It is not 3rd percentile. So any height velocity below 25th percentile is significant. So the same boy that you saw earlier was seen after 6 months and he has grown 2.5 centimeters in 6 months. So change in height over change in time gives you 5 centimeters as annual growth velocity. And that's what I have plotted here. And you see it is between 25th and 50th percentile for his age. So this boy is normal. He has familial short stature. He needs no more investigations. These are the normal. If you don't have the velocity charts, you can remember these rough figures. A kid grows 24 centimeters in the first year, 12 in the second, 6 between 6th in the 3rd year, and thereafter until puberty 5 centimeters per annum. And in puberty, you need to have the charts. These are the Indian growth velocity charts for girls. Then you look at the proportion of the child. Is this child disproportionate? If yes, then where is the disproportion? Am I looking at a child with short legs, in which case it's skeletal dysplasia, or am I looking at a child with short spine, in which case you're looking at metabolic syndrome or storage disorders and very rare skeletal dysplasia such as spondyloepiphyseal dysplasias. Now these are the upper segment, lower segment ratios for you to remember. At birth, it is 1.7. At 3 years, it is 1.3. At 9 years, it is 1. And in adolescent, it becomes 0.9. Then look for typical features. Like here, for example, you see a girl with classic webbing of the neck. She has Turner syndrome. You see a 10-year-old who looks so immature, central body fat. This is growth hormone deficiency. Then always get into a habit of performing sexual maturity rating, but beware that you must take permission of the child and the family. And if they deny, then you can keep these cartoons in your clinic and ask the child to actually mark what they feel is their sexual maturity rating. And lots of studies have shown that SMR comes pretty close, even when it is marked by your patient. These are some of the clinical clues for short stature. If there is infantile appearance, micropenis, you're looking at growth hormone deficiency or multiple pituitary hormone. If there is goiter, macroorchidea, hypothyroidism. In precocious puberty, if there is no growth spurt, no underarm pubic hair, it's hypothyroidism. And you saw the first case like that. Then short metacarpals, I have already mentioned. Parathyroid disease, Turner syndrome, short gene defect. Now, how do you investigate a short child? These are level 1 investigation, hemogram ESR, liver kidney function test, calcium phosphorus alkaline phosphatase. Now in North India and even in Central India and Maharashtra, now we do antigliadin and transglutaminase antibodies. Always think of Turner in a girl. Any unexplained short stature in a girl child, do a karyotype. Thyroid function test and bone age. Bone age is a very simple, very reliable tool, and this is what it tells you. It speaks of the skeletal maturity. It is very closely tied with sexual maturity rating. It speaks of the remaining growth potential. You can do a height prediction using bone age. And normally, it is within 10% of the chronological age. Or for all practical purpose, if the gap between bone age and actual age is less or more than 2 years, then it is significant and you need to investigate. There are many methods of bone age assessment. Use any of these. Tanner Whitehouse, Grulich and Pyle, Gilsands and Ratib or bone expert. Don't use the method of number of carpal bones minus 1 or 2. This is unreliable method. For those who are interested in doing their own bone ages, here is an application for Android that you can download and use. Then level 2 investigations are best left for specialized units. You do IGF-1, IGF binding protein, growth hormone stimulation test, neuroimaging, and as I said, these are best left for specialized units. Now, some of my last slides now. Approach to a short child. When you find that a child is short, first ask yourself, is it abnormal looking? If yes, can I diagnose a syndrome? Is it Turner, Noonan, Down? If looking peculiar but not a syndrome, is it disproportionate? If it's a severe disproportion with short legs, it's skeletal dysplasia. If it is severe disproportion with short spine, it's storage disorder. If it's a mild disproportion, it can be hypothyroidism or constitutional delay. If it's a normal looking child, I would do a growth velocity assessment. So low growth velocity, do a bone age. If it is retarded, it's an endocrine disease. If growth velocity is low and bone age is normal, you are looking at a short normal child. If the growth velocity is normal, it's a short normal child. And in India, when growth velocity is not available, your friend is bone age. So you should rely more on bone age. These are some of the diagrams which show what happens to children if not treated. This is a growth hormone deficient child that I had never received treatment, and see as the age grew how short the child has remained. Whereas this is a child who was growth hormone deficient, received growth hormone therapy at the age of 6 years, and she has now reached a final height of 150 centimeters. So growth hormone therapy in growth hormone deficiency is very, very rewarding. I have a number of patients who have reached height beyond 5 feet who have received growth hormone therapy. However, in idiopathic short stature, unlike the last child, you get a very mild improvement. A very mild improvement after 7 or 8 years of growth hormone therapy. This was a growth hormone deficient child, diagnosed very late, picked up late and treated, still reached a height of 155 centimeters. Now, the growth charts that I showed you are all available on IIP website to download. www.iipindia.org. These are some of the templates that I have created for researcher. Anybody who wants to do research in anthropometry and growth, please write to me at vamankadilkar@gmail.com and I'll send you these templates which help you to do research. Indian Academy of Pediatrics has 2 years ago published Indian Academy of Pediatrics textbook on pediatric endocrinology, which is available with JP Brothers as well as on Amazon.in. And anybody who is interested can buy this book and it will be useful text. To conclude my talk, use IIP growth charts to diagnose growth abnormalities in Indian children. Trend over a period of time rather than a single reading is more important. Systematic approach is necessary to diagnose short stature. Bone age is very useful tool and avoids unnecessary tests. Specialized tests such as growth hormone stimulation tests may best be left for specialist centers. Thank you.
Resume, sir.
Yeah, so shall I stop sharing the screen now?
Yes, sir.
Okay.
Vijay Umar. Vijay Umar.
I'll read.
Yeah. Your comments first, then we will go to the chat box.
Okay.
There are a lot of questions in the chat box. Okay.
So thank you, sir, for that excellent discussion. And so there are few questions in the chat box. Sir, shall I read it, sir?
Yes, please. Yeah.
One question is from Dr. Ayush Gupta. Why FSH increased in peripheral precocious puberty? After that case of hypothyroidism, I think he has asked that question. Why FSH increased in peripheral precocious puberty?
Right. See, that's particularly seen in hypothyroidism. It's pseudo precocity. And what happens is that when the TRH is so high, it not only stimulates the TSH, but it also stimulates FSH because there's molecular mimicry. Therefore, you get a higher FSH. Also, because of the ovarian cyst that form, there is a positive feedback between ovary and pituitary. So the FSH actually goes high.
Sir, another question.
Yeah.
Significance of rapid pubertal changes, etc. Example, thelarchy to puberty in 6 months in a 10-year-old girl. Born age 12 year. What is the significance?
Right. See, there are certain conditions that make a child more prone for rapid advancement of puberty. And those are, number one is an SGA baby. A baby who is SGA is likely to start puberty early as well as progress through puberty very fast. So that's one tricky situation where you cannot really depend upon the bone age alone or just the onset of puberty. Normally what would happen is from thelarchy to menarche, it takes about 30 months. But it can be anything between 18 months to 13 months. But SGA babies are those who would progress very rapidly through puberty, and then you see this. And second group in which you are likely to see this is peripheral precocious puberty, such as McCune-Albright syndrome. Between thelarchy and menarche, you may only have 2 or 3 months. So these two situations I would be very careful with.
Yes, sir. A question from Dr. Ashok Kumar. Is there an entity like partial growth hormone deficiency?
Yes. Now see, people have struggled with this kind of a definition of growth hormone deficiency, but it exists. Now to give you an example, like hypothyroidism, you may have a child with primary hypothyroidism whose TSH is just about 10 or 15. Whereas there's another one whose TSH is 1000. Now the child with 1000 TSH has severe, and a child with say TSH of 10 has a mild deficiency. Now very similarly, you can have a central hypothyroidism which is mild and a central hypothyroidism which is severe. So growth hormone deficiency is a continuum from mild to severe. And those who are not severe are sometimes referred to as partial growth hormone deficiency. And I think there are no standard definition by cutoffs. But many people in America believe that those who are between 5 to 10 nanogram per TL on stimulation are partial. And those who are about 10 are normal. But it's a matter of contention. But logically, I think we all can believe that like in all pituitary disorder, there is a grading of severity. Why not growth hormone deficiency? So that is called partial, or it used to be called growth hormone insufficiency when I was getting trained at Great Ormond Street between 94 and 97. So it used to be called growth hormone insufficiency. Now it is called partial growth hormone deficiency.
Vijayama, may I ask a question? Vijayama?
Yes. Dr. Ananthakesavan, you can ask question.
Sir, in 2-3 cases you mentioned about IGF-1. So whether you will do IGF-1 or growth hormone as a, so can you use IGF-1 as a screening test, or is there any limitation for using IGF-1? Because IGF-1 is simple. For growth hormone, we have to admit the patient, we have to do a challenging test. So we can substitute IGF-1 for growth hormone for screening test.
Yes, I think for children who are older than 3 years of age, IGF-1 can be used as a screening test. But in children who are younger than 3, you have to use IGF binding protein 3 as a screening test. It is very rare that a child who has a normal IGF-1 has growth hormone deficiency. It's exceptional. So it can be used as a good screening test beyond infancy. But in infancy, use IGF binding protein 3, IGF BP3.
So you know to do growth hormone estimate, all tests as a screening.
Yeah, as a screening, use IGF-1 in older children, younger children, IGF BP3.
Yeah.
And if it is low, then do a growth hormone stim test.
Thank you. Sir, there is another question from Dr. Hari Kumar. What is the upper age limit when growth hormone therapy may be started?
Right. I think more than age, I would go by bone age. If the bone age is more than 14 in a girl and more than 16 in a boy, I will not give growth hormone because it is not going to work.
Okay, sir. Another question from Dr. Satish. Sir, any medical treatment for achondroplasia to increase height?
Not as yet. Not as yet, but I think molecules like atrial natriuretic peptide, etc., are in the pipeline.
Yes, sir.
But not yet. Yes.
Dr. Jitesh Pillai, head circumference growth after 5 years, which chart to look?
Very few are available actually. Very few charts are available on head circumference beyond 5 years. I think, see, beyond 5 years, the head growth is very, very little. Most of the head growth is complete by 5 years. That's why you don't have growth charts beyond that.
Yes, sir. Is there any particular time of day to collect blood samples for growth hormone?
See, if you have to collect or rather measure growth hormone, we must do a dynamic stimulation test. There is no point in checking growth hormone without stimulation. It gives you no information. And when you do a growth hormone stimulation test, you ask the patient to come fasting early morning.
Yes, sir. Dr. Rajesh, what are the indications where you are commonly using growth hormone therapy and what are the common side effects observed?
Okay. So common indication, I think the first one is growth hormone deficiency, either congenital or acquired. Second one, I use it for Turner syndrome. And third indication in my practice would be SGA, small for gestational age babies. Fourth one would be idiopathic short stature, but that's a very small number. So growth hormone deficiency, Turner syndrome, SGA, and idiopathic short stature, those would be the sequence in which I use it. And there's a small group of children with Prader-Willi syndrome on whom I use it. Side effects, see, generally very well tolerated. It may rarely cause mild headaches in the first 2 weeks and can cause some water retention. There are some serious side effects of growth hormone therapy, which include slipped capital femoral epiphysis, then kyphoscoliosis, which may get worse, and very rarely you get benign intracranial hypertension. But these side effects are very, very rare. It does not lead to any increase in malignancy, primary or secondary. So generally a very safe medication. if used in the right indication under good monitoring.
Okay, sir. I think thank
Any
you.
reason for your craniopharyngioma very large, but without any other features of intracanal? Any reason? Any explanation? The large craniopharyngioma.
Yeah, craniopharyngioma is a tumor which kind of grows at the cost of the brain cells. So therefore, in lot of cranios, until they grow very large, you don't get any symptoms. But growth failure is almost universal. In fact, I'll tell you a story of a child at Great Ormond Street when I used to be there now nearly 25 years ago. See, we saw one child with growth failure. And the MRI that time available even at GOS was just 1 Tesla. And we did and just to let you know that there are more MRI machines in Maharashtra than in whole of United Kingdom actually. But the thing is, we found nothing. Growth failure, growth failure, growth failure, and growth hormone insufficiency without race prolactin. And every time I saw the child, I got worried. And Dr. Stanhope, who was my boss, always said that remember, if you get a kid who has such growth failure and you cannot find anything else, I will not be surprised if a tumor comes up after a few years. And I didn't believe in him that time because MRI used to come normal. 3 years later, that child showed up a mass on pituitary gland. So growth failure is a very, very, very sensitive parameter even before your intracranial pressure starts coming up. So monitoring, I think, is of $1 million, not only in pituitary disease, any disease for that matter. Silent celiacs, I see them every now and then. Silent celiacs, not even anemia, but you do they have growth failure, you do the biopsy, you get celiac disease. So I think if a kid is not growing, it's a little bit like a plant really. Anything grows wrong with a sapling or a plant, it just stops growing. It doesn't produce flowers and fruits. So I think child is very similar to that. If there's growth failure, we have to look carefully. But growth failure speaks of some disease going on there.
We have few more, three more
questions are there. Okay.
Yeah, that shall I ask, sir?
Sure. Yeah.
So there is one question. What parameters should be monitored during growth hormone therapy?
Right. Now, I would consider them as anthropometric parameter and biochemical parameters. In anthropometry, which is the most important, I would be checking height 3 monthly, weight 3 monthly, and that's it. And plot it on a growth chart. You expect about doubling of the growth velocity in the first year and 2/3 of that in the second year. Monitoring biochemically, I would monitor blood sugar, HbA1c, IGF-1, free T4 and cortisol 6 monthly, and a bone age yearly. That's it.
Yes, sir. Another question is from Dr. Rajesh. He is from Calicut Medical College. He is with me. He is in the endocrine clinic also. A child is having mild scoliosis. Is it a contraindication for growth hormone therapy?
Mild scoliosis is not, but when you treat a child who already has a scoliosis with growth hormone, you have to be in close touch with your orthopedic colleague and they calculate that angle on 6 monthly basis. And if the angle is increasing, you need to stop growth hormone. But mild scoliosis is not.
Okay, sir. Is from Dr. Murali, is growth hormone treatment indicated in SGA babies if their growth hormone levels are normal even after stimulation?
Yes. In fact, in SGA who fail to catch up, you do not perform growth hormone stimulation test. You start growth hormone in an SGA who has failed to catch up without performing the growth hormone stimulation test. There are 2 indications in which you do not perform GSTIM test. Number 1, SGA who failed to catch up, and second one is Prader-Willi syndrome, as well as you do not do that in Turner syndrome. So 3, I would say 3 indications in which you don't need to stimulate the growth hormone.
Another question from Dr. Ajit Kumar. Even if it seems to be familial short stature, should we test for growth hormone?
Yes, you should, because some families have familial growth hormone deficiency, which may be very mild in an adult. and therefore they are not that short, but the child may manifest more severe. So I think if one of the parent is significantly short, you should suspect a familial GHD and should do that.
One more question is there, Vijaykumar. If there is any entity called partial growth hormone deficiency.
Yes, that I think sir has answered.
Answered that. Okay.
Yeah.
I missed that. Okay. Then Vijaykumar, now the session is open for discussion. CK sir is there.
Yes, sir.
Shall I ask? Shall I?
Yeah, definitely, sir.
I think that is an excellent, but simplified, and there are so many takers for your way of presentation and talk, and you emphasize really on the growth monitoring. That's the most crucial point you stress all along your talk. My point is, we are a country with large number of growth retarded children. So all these problems will get diluted among these growth retarded children, and picking up certainly need expertise and this type of orientation. And in fact, and I think Vijaykumar a talk on growth monitoring. It's an excellent tool. We thank to David Morley for introducing the Road to Health card years back. I expect your comment, sir.
Yes, Professor David Morley was known as a man who introduced parent-held growth charts.
Yes.
And in the textbook that he wrote called the Pediatric Priorities in the Developing World,
yes,
David Morley actually emphasizes this again and again, saying that pediatrician may not have time, the healthcare worker may not have time. So you give the growth chart to the parent, teach them growth chart, they will monitor, they will come to you whenever there is a growth problem. So absolutely, exactly. A great man indeed. Yeah.
Vijaykumar?
Yes.
If there is no more question, we will close the session.
Sir,
thank you so much. Thank you, sir. Thank you for that excellent talk. Actually, it is very convincing to all of us about the importance of the.
Thank you, sir, very much. Thank you, sir.
Thanks a lot. Thank you.
Thank you.
Thanks a lot, sir.
Thank you. Thanks for the opportunity.
That is wonderful.
And it's very well attended as I see it. Thanks a lot.
Thanks a lot, sir. Very good.
Super.
Now,
I think people not from Kerala, even outside Kerala, lot of people are there, sir.
Yes. Many from outside also joined the
meeting. How many participants there?
Around 165 persons participated in the Zoom, and how many was in YouTube?
17
in YouTube.
Wow.
70.
Amazing.
Very good. Very good.
So thank you, sir. Now over to Dr. Nihas, Secretary IAP Kozhikode, for a word of thanks.
Thank you, Vaman sir, for that nice and elaborative talk on growth charts and enlightening us on the importance of growth chart again. Thank you, sir, for coming to Calicut and giving a nice session for today. I thank Vijaykumar sir for sharing this session. He is the hardcore endocrine person in Calicut, and he is the actually scientific committee chairman of this webinar series also. Thank you, sir, for being with us, and thank you, sir, for sharing this session. I thank Narayan sir and Balachandra sir, the President and Secretary of IAP Kerala, for all the support for IAP Kozhikode. I also thank Anand Keshwan sir and Ramesh sir. I think Ramesh sir couldn't make it today, but he just joined in between and left. He had some other meeting also. So thank you, Ramesh sir and Anand Keshwan sir, for joining us today. All the seniors, CK sir, Shaji sir, and all others joined today. Thank you for joining. All the my dear friends, all other members who joined, thank you for coming today. We'll be having our next session on Monday. That will be on urinary tract infections by Dr. Arvind Bagga. I invite all of you for the next session also. Thank you. Good night.
Thank you.
Thank you, sir. Aman sir, thank you.
Thank you, sir.
Thank you.
Bye.
Vijaykumar, stay 1 minute. whether the Arvind Bagga is confirmed on Monday?
Yes.
Yeah. Arvind confirmed Vijay Mara?
Yes.
Yes. Swati Madam will